In the last video on prostanoid analogs, we saw in detail the actions of prostaglandins. In this video, we will talk about non-steroidal anti-inflammatory drugs. Video notes of this lecture, like all pharma lectures, are uploaded in the app for free download. Before we start, we will just briefly revise formation and actions of prostanoids. So here this flowchart shows the formation of prostaglandins. So these are the prostaglandins which are basically synthesized by the action of COX enzyme, that is the cyclooxygenase enzyme, on arachidonic acid. Now, NSAIDs, that is the non-steroidal anti-inflammatory drugs, act by inhibiting this COX enzyme so that there is decrease in formation and hence action of these prostanoids. So this COX enzyme is of two types, that is COX-1 and COX-2, and both of them have some constitutive actions, that is the actions which maintain the normal baseline physiological functions, while COX-2 can also be induced in some tissues in case of inflammation. So NSAID's pharmacological action is mainly due to inhibition of this inducible COX-2. But it will have the side effects, because if this COX-1 and COX-2 constitutive actions are inhibited, then those will constitute the side effects. So quickly we will revise what are these actions. We have already seen them in previous video. So COX-1 constitutive actions include in stomach. Prostaglandin E1 is responsible for the formation of mucous bicarbonate layer, which is protective against the acid which is present in the stomach. In platelets, this COX-1 leads to the formation of thromboxane A2, which is responsible for platelet aggregation and hence hemostasis. And in fetal stage, prostaglandin E2 is responsible for maintaining the patency of ductus arteriosus. Okay. So this is important because in fetal stage, blood doesn't go into the lungs for oxygenation. It bypasses the lungs, and that happens because of this ductus arteriosus. Then COX-2 also has some constitutive action. One is in kidney. It is released from the JG cells. Basically, this causes increase in the renal blood flow. It causes vasodilation and increase in the renal blood flow, and because of this, there is increase in GFR. And also it decreases the tubular reabsorption, and because of this there is increase in the diuresis, basically increased salt and water loss is occurring. Then by vascular endothelium, this prostaglandin I2 is released because of the action of COX-2, and this is inhibitor of platelet aggregation. We saw thromboxane A2 is promoter of platelet aggregation, and this prostaglandin I2, or also known as prostacyclin, released from the vascular endothelium, is inhibitor of platelet aggregation. Okay. And then obviously it is inducible, which is induced in case of inflammatory sites, and so inhibition of this action is responsible for the action. Now, inhibition of the housekeeping action, I told you, will lead to side effects. So what are these side effects of these NSAIDs? We will talk about the action, but it is important, since this is the fundamental, we will here only discuss the side effects. So inhibition of COX-1, because in stomach it will lead to decrease in mucous bicarbonate layer secretion. So there will be increased chances of gastric erosion, gastric ulcer, and hence gastrointestinal bleeding. Then inhibition of thromboxane A2 production will lead to decrease in platelet aggregation, thus interfering with hemostasis, and there will be increase in the bleeding tendency. Then in fetal stage, if it is blocked, there will be premature closure of the ductus arteriosus. So in pregnancy, if it is given in later stage especially, there will be premature closure of the ductus arteriosus. Then because of the COX-2 inhibition, this PGE2I2 action will not be there, they will not be produced, hence action will not be there. So there will be increased salt and water retention, because that I told you it is important for salt and water loss. So the inhibition of that action will lead to increased salt and water retention. Then endothelial, if COX-2 is blocked, then it increases thrombotic risk, because this PGI2 production is inhibitor of platelet aggregation. So that action is blocked, and this increases the thrombotic risk. Now, we have seen here that platelet blocking causes decrease in the platelet aggregation, while blocking of endothelial COX leads to inhibitor of platelet aggregation. So COX-1 inhibition is increasing bleeding tendency. On the other hand, COX-2 inhibition is increasing the thrombotic risk. Now we have NSAIDs which act on both COX-1 and COX-2 that we are going to see later, that is known as non-selective NSAIDs, and there are NSAIDs which act mainly on COX-2. So the ones which act non-selectively on both, that is they will inhibit both COX-1 and COX-2, for them the major effect is increase in bleeding tendency. Increasing bleeding tendency, because what happens, both of these get blocked in platelets also, in vascular endothelium as well. But platelets are anucleate and they can't synthesize new COX-1. However, vascular endothelium can synthesize new COX-2 enzyme as well. So that's why this increased bleeding tendency is a majority side effect with non-selective COX-1, COX-2 inhibition. However, with selective COX-2 inhibition, this remains intact. So effect on platelet aggregation remains intact. But inhibition of platelet aggregation doesn't work. So there is increased risk of thrombosis with COX-2, selective COX-2 inhibitors. That in detail we are going to see later, right? Now, coming to the action, I told you that NSAIDs act mainly by blocking the inducible COX-2. So, they are basically decreasing the inflammation. See, this inflammation is normal protective response of body in response to injury or foreign agent, and this is important for tissue protection against this injury or foreign agent. But when this inflammation becomes uncontrolled or is due to some autoimmune diseases, then it becomes damaging for the body. So in that cases, it is important to control these inflammation. And during this inflammation, what happens that locally where tissues are being damaged, prostaglandins are produced and they cause the vasodilation, an increase in the vascular permeability, due to which there is fluid leakage, and also the leukocytes will move out. And also actually on this endothelium there is expression of these adhesion molecules on which the leukocytes attach and roll, and then because of increase in vascular permeability, these leukocytes move by diapedesis into the region of damage or region of inflammation. So all this can be controlled by giving NSAIDs which decrease the inflammation, because they are decreasing the formation of these prostaglandins. But remember, they are decreasing the inflammation and hence that the damage which is caused by this inflammation, but they are not acting on the cause of inflammation. So that is very important, that they do not act on the cause of the inflammation. So after this, we'll just finish by looking into some more actions of the prostaglandins. Again, we have dealt with this in the previous video, so I'm not going to talk in detail. Just small things we will touch, because that is important when we will talk about the actions of NSAIDs or uses of NSAIDs. So in uterus, we have seen that prostaglandin E2 is essential for onset of parturition. So if this is blocked, what will happen? The onset of parturition will not occur. In fact, when these NSAIDs are given in pregnancy near the term, then they will delay the parturition. And also prostaglandin is responsible for dysmenorrhea, that is pain during menstruation, because this prostaglandin is produced during menstruation and this is responsible for the pain. So our NSAIDs can be used as a treatment for dysmenorrhea. So fundamentally NSAIDs have following actions. One, they are anti-inflammatory, we have already seen, but they are also acting as analgesics and antipyretics. That is because of their action on the sensory nerves and also on the central nervous system. So one is the prostaglandins are released from the damaged tissues and they act on the endings of the sensory nerves. So they basically sensitize the endings of the sensory nerves and they lead to increase in pain to the stimulus which is causing pain. See here, lot of chemicals will release which are stimulating the sensory nerve endings, and these prostaglandins are also released and they increase the sensitivity of these sensory nerve endings. This is known as hyperalgesia. So with the same stimulus, now more pain is going to occur. So our NSAIDs are going to block the production of prostaglandins in these from these damaged tissues and thus decreasing the pain. How they act as antipyretic? Well, we know that how fever occurs. Fever occurs because of certain interleukins which are released, and they act on the vessels in the preoptic area, and in these vessels the endothelium releases prostaglandin E2 because of the action of these interleukins. This prostaglandin E2 then crosses blood-brain barrier, act on the hypothalamus. There are certain thermosensitive neurons, there it acts, which causes increase in the body temperature. So again, this production of prostaglandin E2 in these vessels is blocked by NSAIDs. So three fundamental actions of NSAIDs we should remember: analgesics, antipyretics and anti-inflammatory. However, we will see that various NSAIDs differ in the amount of these actions. Some may have more analgesic action, some may have more anti-inflammatory action, that we are going to see further. So broadly, NSAIDs are classified as non-selective COX inhibitor, which is going to inhibit both COX-1 and COX-2. Then preferential COX-2 inhibitor, which will inhibit both COX-1 and COX-2 but inhibit COX-2 much more, and selective COX-2 inhibitor. Okay, so remember, pharmacological action is mainly due to inhibition of COX-2. Now, non-selective COX-2 inhibitors are further subclassified based on their chemical nature, right? We have salicylates. The drug in this is aspirin. Basically, it is acetyl salicylic acid. Then we have propionic acid derivatives, phenamates, enolic acid derivatives, acetic acid derivatives, and pyrazolone derivatives. Now, we will discuss about aspirin as a prototype drug. These other drugs we are going to discuss in the next video, where we'll just compare and see that which of the activity is more in which drug and in which population they are used more, like that. Certain characteristics we are going to see. So, discussing aspirin as a prototype drug. So first remember that all the NSAIDs bind heavily to plasma proteins, and because of this we will see displacement reactions with other drugs. Displacement reactions, we have seen about them in our pharmacokinetics videos. Basically what happens if there is a drug which is already bound to the plasma protein, now you give another drug B which also can bind to plasma proteins. So this drug will also compete for binding with the plasma proteins, and this original drug is going to be displaced. So the free concentration in the blood is going to increase in the of this drug, right? So that means there will be chances of toxicity of this drug. So in this case, it is needed that the dose of this drug need to be decreased, right? Second, these organic acids first undergo some biotransformation in the liver and then are excreted by kidney by tubular secretion. So these drugs basically are not given in advanced liver and renal failure, right? Also, we will see later that on chronic use, actually they can cause both hepatic damage as well as kidney damage. Then thirdly, these drugs are lipophilic and can penetrate CNS. And because of this lipophilic nature, they can also reach the joints. So they are used in different types of arthritis where they can reach the joints and they can have high concentration in the synovial fluid. So moving on to aspirin. So aspirin is a prototype drug, as I told you, and this drug basically is the only drug which causes irreversible inhibition of COX. Okay, so this is exception. All other NSAIDs cause reversible inhibition. This causes irreversible inhibition of COX. So what happens? As aspirin is getting absorbed from the intestine, this you see, aspirin is basically acetyl salicylic acid. So in the portal circulation, this acetyl part gets attached to the COX of the platelets, right? In the portal circulation, platelets will be there. So there is acetylation of the COX enzyme of the platelets, and this is covalent acetylation, that is irreversible, and this is especially important for platelets. So there is irreversible inhibition of platelets COX action. And the amount which goes into circulation, that will also cause some irreversible inhibition of COX in different tissues. But what happens from the portal circulation as it enters into the liver, there is deacetylation of this aspirin. So much amount of salicylic acid is going into the circulation, and that is important for remaining actions. But remember that this salicylic acid is only causing reversible inhibition. The acetylsalicylic acid, the amount which goes into the circulation, this acetylation of the COX is responsible for irreversible inhibition. Now, why this is important, especially for platelets? Because it is irreversible inhibition and platelets are anucleate. They do not have the nucleus. So, they cannot synthesize new COX enzyme. So, this effect on platelets will remain for the lifetime of platelets. Right, until unless new platelets are synthesized, this effect will only be there, and this is for 8 to 10 days it will remain. So, duration of action of aspirin basically depends on the turnover time of COX, that is how long the cells are taking to synthesize this COX enzyme. For other cells, it will be different. For platelets, it is for the lifetime of the platelets until unless new platelets are synthesized. Moving on to uses of aspirin. So, aspirin is used as an analgesic. It is not very high dose is used, 0.3 to 0.6 gram is used. It can be used only for inflammatory pain, very important, because in inflammation we have seen that prostaglandins are released and they are going to sensitize the nerve endings. But they are not used for visceral pain, ischemic pain and neuropathic pain, very important. NSAIDs are used mainly for inflammatory pain. And this aspirin is also used for mild migraine, that we have seen in our migraine video, that for mild migraine, aspirin and even other NSAIDs can be used. Other NSAIDs can also be used for moderate migraine. Then it can be used as antipyretic. We know the mechanism of action, how it will act, but because paracetamol is safer, it is preferred. Plus, paracetamol can be given in children as well. Aspirin is contraindicated in children less than 12 years of age. Okay, so in children it is not used. Third, anti-inflammatory. Yes, higher doses are needed, very important. So you see here analgesic 0.3 to 0.6 gram. Anti-inflammatory, it is 3 to 6 gram per day. That is 10 times of the analgesic dose. So that's why it can't be given for long duration, because it is not tolerated well when given in such high doses. Only anti-inflammatory action is in case of acute rheumatic fever, where it is the first drug which is used in all cases. But it starts giving symptomatic relief in acute rheumatic fever in 1 to 3 days, and after 1 week even the dose needs to be reduced. Dose reduction starts after 1 week, and within 2 to 3 weeks it is removed. So it is not for very long term that this aspirin is given for acute rheumatic fever. Okay, so remember, for other anti-inflammatory actions like in rheumatoid arthritis, osteoarthritis, this aspirin is not used because it cannot be tolerated in such high doses for such long duration. Then very important, and this action is unique to aspirin, that it is used for secondary prophylaxis in myocardial infarction and post-stroke. So any cardiovascular events which occur, low dose aspirin is used. Why? Because of its unique action on irreversible inhibition of COX in platelets. Okay, so what happens? That as this aspirin is given, more and more irreversible inhibition of COX in platelets continues, and even more platelets are being added in the circulation. There also that inhibition occurs. Okay, so this causes decrease in platelet aggregation and hence decreased chances of thrombosis. Okay, so these risks are decreased, but remember, it is only low dose which is given, because if you give in higher doses, then it is not tolerated well. So here low dose also works. Why so low dose even works for platelets? Well, because as I told you before, that aspirin directly, as it is entering into the portal circulation, directly here only it is causing the acetylation of COX of platelets. Even it has not gone into the liver. So that is why even low dose aspirin works for this secondary prophylaxis in MI or stroke patients. But very important thing you remember here, that if you combine this low dose aspirin with other NSAIDs, then there is loss of cardioprotection. So there might be patients of MI who are taking this low dose aspirin, but they are having some other diseases as well. Say suppose the person is having rheumatoid arthritis or osteoarthritis. If you give other NSAIDs in these patients, then this effect of aspirin is lost. Why so? Well, both of them compete for the same site of COX. So say suppose this is the site of COX where acetylation is occurring. Now you give other NSAID, it also acts on this, but this is reversible inhibition, and this caused by aspirin is irreversible inhibition. So now aspirin is not able to irreversibly inhibit the COX enzyme because of the effect of NSAID, right? So there is loss of cardioprotection in these patients. Instead of NSAIDs for that inflammatory condition, we need to give some other drug, right? Now moving on to side effects, very important side effects. One, it irritates the gastric mucosa. You see that it is an acid. These all NSAIDs are acid. So they irritate the gastric mucosa, and also they cause the decrease in production of the prostaglandins. So there is increased chances of gastric bleeds. We have seen this where we were talking about the constitutive COX-1 action. Okay. Also, aspirin undergoes ion trapping. What is this? This again we have seen in our videos on pharmacokinetics. So what happens that gastric lumen pH is 3 and aspirin has a pKa of 3.5. So in this state where the pH of the medium is same as at the pKa of aspirin, aspirin is in unionized state. Now it can easily cross through the barrier because it is unionized. Ionized means it cannot easily cross through the barrier. Unionized means it is lipophilic, it will easily cross through the barrier. And within the gastric mucosal cell, as it enters, the pH in the gastric mucosal cell is quite high, which is 7.1. So there it ionizes and it gets trapped in the gastric mucosal cell. This is known as ion trapping, and because of this ion trapping, aspirin remains in that mucosal cell much longer, and hence there are high chances of damage. So NSAIDs are contraindicated in patients of peptic ulcer. Then there is increased bleeding tendency again because of the blockage of platelet COX. So this aspirin is contraindicated in patients with bleeding disorders, and you have to stop the drug 1 week before elective surgery. Why 1 week before? See, the lifespan of platelets is 8 to 10 days. So by 1 week, some platelets will recover. See, when you give aspirin in the circulation, we will have some new platelets who have just come into the circulation. There will be some older platelets who have already been in the circulation for say suppose 5 days, 4 days. So now when I give aspirin and I stop 1 week before the surgery, these platelets within next 5 days they will be replaced by new platelets. So there will be some platelets which will be newer on which aspirin action is not there, right? So we have to stop this drug at least 1 week before elective surgery. Then a unique side effect of aspirin as compared to other NSAIDs is salicylism. What is that? See, aspirin actually increases the metabolism. Because of this, there is increase in glucose utilization. So this can lead to hypoglycemia. Okay, so we have to avoid in diabetics because this development of hypoglycemia can become very unpredictable. Then also because of increased glucose utilization, that is increased metabolism, there is increase in carbon dioxide production, and hence this carbon dioxide leads to stimulation of chemoreceptors, and this stimulates the respiratory rate and depth of respiration, causing increased carbon dioxide washout and respiratory alkalosis. Okay, so there is increase in the respiratory rate and depth causing respiratory alkalosis, and this is compensated by body by renal excretion of bicarbonate ion. So more alkalosis is occurring in the body. So body tries to bring back the pH by excretion of the alkali, that is the bicarbonate ion. But if aspirin is given in higher doses, it can directly lead to respiratory depression because it itself is an acid. It can directly lead to respiratory depression, and this will lead to respiratory acidosis. Now you see, before already bicarbonate is lesser in body and you are causing respiratory acidosis. So for this compensation we need bicarbonate, but bicarbonate your body has already excreted out. Okay, so the signs and symptoms which occur in this condition, that is known as salicylism. Okay, so these signs and symptoms include hyperventilation, excitement, tinnitus, vertigo, and there is electrolyte imbalance as well. Now Other side effects include hepatic injury. I told you all NSAIDs can cause hepatic injury as well as renal injury. So hepatic injury it can cause, so it is contraindicated in chronic liver disease. It is even contraindicated in children less than 12 years of age because there is a risk of Ray's syndrome. Ray's syndrome is basically a condition in which there is hepatic encephalopathy. There can be hepatic failure which leads to encephalopathy. It is a rare condition, but it can occur in children having a viral infection. And this aspirin is antipyretic, isn't it? So if you give in a child with viral infection this antipyretic, then it increases the risk of Ray's syndrome. So it is contraindicated. Except this aspirin is used in children only in case of acute phase of Kawasaki disease. That is the only exception. Then in pregnancy if you give, then there is chances of delayed prolonged labor, premature closure of ductus arteriosus. This we have seen that the prostaglandin E2 is responsible for onset of labor and also for maintenance of patency of ductus arteriosus. So if you give near term, then there are chances of premature closure of ductus arteriosus. Then this is an acid, organic acid. Okay, so basically this is related to mainly aspirin, which is responsible for Ray's syndrome, and others they are applicable to other NSAIDs as well. So they decrease the uric acid secretion because they are organic acid, and in the tubules uric acid is secreted by secretion, tubular secretion, and these organic acids are also secreted by tubular secretion. So they will compete with each other, thus causing decrease in uric acid secretion. Hence, it is contraindicated in gout. It can also lead to hypersensitivity. In fact, one feature is aspirin-induced asthma. And if there is aspirin-induced asthma, then there is cross-reactivity with other NSAIDs as well. So, other NSAIDs are also contraindicated if there is hypersensitivity reaction to aspirin, except nimesulide that we are going to see later. Nimesulide doesn't cross-react. That is the only property. Otherwise, nimesulide is banned in many countries, but only in case of aspirin-induced asthma, nimesulide can be used. Then it can cause analgesic nephropathy on chronic use. Okay, so there is tubulointerstitial nephritis and papillary necrosis. So, on chronic use of NSAIDs, there can be analgesic nephropathy as well, right? Now moving on to drug interactions, that is the last part we are going to see. So what are the drug interactions? First, I told you that all NSAIDs are bound heavily to the plasma protein, so there can be displacement reactions with drugs like warfarin, that is the oral anticoagulant, sulfonylurea, which is a hypoglycemic drug used in diabetics, then methotrexate, anti-cancer drug, and phenytoin is an anti-epileptic drug. So in patients who are on these drugs, if aspirin is given, then there will be displacement of these drugs. Okay, so protein is already bound with drug A. If you give drug B, protein will bind to drug B and some of this drug is going to displace, and the levels of these drugs are going to increase in blood, and this can lead to toxicity. So we need to consider decreasing the dose of these drugs. But this warfarin, which is oral anticoagulant, now we have seen that aspirin is already decreasing the platelet aggregation, and if you are giving it with oral anticoagulants, then it will further increase the bleeding tendency. Plus warfarin levels are also going to increase, so that is also going to increase the bleeding tendency. So these drugs are best avoided with the oral anticoagulants. Then aspirin given with diuretics and ACE inhibitors, it decreases the effect of these drugs. So antihypertensive action is decreased. Why it is decreased? Because we have seen that prostaglandins are important for salt and water loss, right? So if you give NSAIDs, that salt and water loss is blocked. Okay, in fact there is increased salt and water retention that we have seen when we were seeing the constitutive action of COX-2, right? So increased salt and water retention, which is totally opposite to the action of the diuretics. So there is decreased effect of diuretics if these drugs are being used as antihypertensive. Then aspirin given with probenecid. Probenecid is a drug which increases the uric acid excretion in case of gout. Okay, so we have seen that aspirin actually competes with uric acid for tubular secretion. So aspirin decreases the uric action of the probenecid, right? So those were the drug interactions. So what we have seen in this video, we briefly saw the synthesis of the prostaglandins, the actions of the prostaglandins, the constitutive and inducible actions of COX-1 and COX-2. Then we also saw the classification of NSAIDs and what are the major actions of the NSAIDs. Then we saw the classification of non-selective COX inhibitor, and in this we saw mainly aspirin in detail. In the next video, we are going to talk about other NSAIDs, the feature of other NSAIDs, something like this, where we will focus only on the key points of other NSAIDs. Thanks for watching the video. If you liked it, do press the like button, do share the video with others, and don't forget to subscribe to the channel Physiology Open. Thank you.